In this video, we will demonstrate a total knee arthroplasty procedure using mechanical alignment. Unlike procedures that aim to replicate the natural anatomical alignment, our goal here is to align the prosthesis along the mechanical axis of the limb. The mechanical axis of the lower limb is a straight line running from the center of the hip joint through the center of the knee to the center of the ankle joint. This line represents the weight-bearing line of the limb. Our objective is to position the prosthesis on the femur and tibia perpendicular to this line. However, as the mechanical axis cannot be directly measured during surgery, we use the individual anatomical axis of the femur and tibia as references for the bone cuts. On the femur, the difference between the two axes is measured preoperatively and is typically 5 to 7 degrees. On the tibia, the anatomical axis is parallel to the mechanical axis. Achieving a biomechanically functional knee involves considering also other parameters, such as the rotation of the prosthesis. Therefore, each bone cut has specific parameters that we need to consider, which we will discuss during the surgery. The saw cuts will determine the position of the prosthesis and how the knee functions throughout its range of motion. The saw cuts will result in a gap between the tibia and femur. When the knee is extended, the extension gap is formed by the distal femoral cut and the tibial cut. When the knee is flexed, the flexion gap is formed by the posterior femoral cut and the tibial cut. To ensure proper joint function, it's crucial that both extension and flexion gaps are symmetrical. This will become more evident once the saw cuts are made and we evaluate both gaps. We will perform a total knee replacement surgery for varus-type arthrosis, and we are demonstrating the operation with a cadaver. At the beginning of the surgery, check the range of motion of the knee joint by extending and flexing the knee. This should be followed by testing the stability of the knee joint in both extension and semiflexion. Should there be a deformity that can't be corrected with gentle manual correction at this stage, it may indicate a technically more challenging surgery. If the knee joint presents with significant ligament insufficiency, choosing implants with stabilizing qualities should be considered. Knee replacement surgery is performed in a supine position. We recommend using both distal support to keep the knee in flexion and a lateral support to provide stability in the lateral direction. The knee replacement surgery is performed under either spinal or general anesthesia. The surgery can be performed safely with or without a tourniquet. However, if a tourniquet is used, the cuff should be placed as proximally as possible to prevent it from getting in the way of the incision. Before making the incision, the anatomical landmarks can be traced on the skin with a soft marker. Let's start by tracing the medial edge of the tibial tubercle, then the borders of the patella, and next the medial border of the patellar tendon, as well as the length of the incision proximally. Depending on the patient's anatomy, you should extend the incision 5 to 10 centimeters proximally from the superior border of the patella to gain sufficient exposure for reliable prosthetic positioning. In total knee arthroplasty, a straight skin incision with a medial parapatellar arthrotomy can be considered the golden standard. When planning the incision, you should also prepare for the closure of the wound. With medial parapatellar arthrotomy, the skin incision over the patella will need to be performed slightly medially from the midline. There is hardly any subcutaneous tissue on top of the tibial tuberosity, so for safe wound closure, it's recommended to extend the distal end of the incision medially to the tuberosity. When making a skin incision, a scalpel or diathermy can be used. Always perform an incision with the scalpel perpendicular to the skin. An assisting surgeon can help by using a retractor for better visibility and access. Continue perpendicular to the subcutaneous tissue and avoid damaging the muscles, the quadriceps tendon, and the patellar tendon. All bleeding vessels should be cauterized with diathermy. A gentle tension provided by the retractor can also help with the dissection. Additionally, you can angle the scalpel to proceed carefully separating the different layers. The dissection is continued until the fascia is clearly visible and the landmarks for the arthrotomy are identified. Extend the skin incision proximally for optimal exposure and eventual implantation of the components. Excessive release of the subcutaneous tissue should be avoided to ensure proper wound healing. Especially when the subcutaneous layer is thicker than seen here, it's important to stay perpendicular to the skin and the underlying tissue. Otherwise, you may stray either too laterally or medially from the skin incision. Now we've exposed the surface of the fascia sufficiently and can identify the landmarks for the arthrotomy: vastus medialis muscle, quadriceps tendon, the patella, and the patella tendon. For demonstrative purposes, we'll trace the incision for the arthrotomy at the fascial level. When performing an arthrotomy, plan for the closure of the wound. With wound closure in mind, perform the arthrotomy about 2 to 3 millimeters lateral of the medial border of the quadriceps tendon. This will leave enough tendon tissue for the wound closure. Same here at the medial border of the patella. Leave 2 to 3 millimeters of soft tissue at the medial edge of the patella. And at the tibial tubercle, pay attention to the patellar tendon and leave it intact. The medial side of the retinaculum can be released so that the arthrotomy can be closed without any tension. The arthrotomy can be performed with a single incision. Here, the scalpel can be safely pressed into the underlying bone. Make a slight medial curve at the patella. In the distal part of arthrotomy, the Hoffa's fat pad can be incised while advancing perpendicular to the tibial articular surface. The scalpel can be safely pressed to the bone. Simultaneously, the anterior horn of the medial meniscus is split. Now that the meniscus is out of the way, we can perform a subperiosteal release to help with the upcoming flexion of the knee and averting the patella without causing any unintentional tears. Hold the scalpel parallel to the surface of the bone and avoid horizontal incisions to prevent damage to the joint capsule. The subperiosteal release can be continued about 2 to 3 centimeters distally and medially to the level of the edge of the medial condyle of femur. At the next step, the knee is fully extended to reduce the tension on the patella. After that, the patella is everted. Grab the patella with a gauze because the synovial fluid can make it slippery, and gently start flexing the knee. The purpose of the medial release during the arthrotomy is to get the tissues separated from the tibia in a controlled manner so that during the flexion of the knee, there won't be any uncontrolled tears in the tissues. Also, pay attention to the patellar tendon's insertion site during flexion, because in some cases, for example due to a low-lying patella, the patellar tendon may start to tear from its insertion. The knee is then flexed slowly and carefully. When the patella is everted, the Hoffa fat pad can be identified on the ventral side of the patellar tendon. It may be quite prominent, and you may want to resect some of it for better visibility. However, do not remove the entire fat pad to maintain optimal blood supply to the patellar tendon. When resecting the fat pad, take extra caution to avoid injury to the underlying patellar tendon. The patellar tendon can be palpated during the resection of the fat pad, and thus you can make sure that the tendon remains intact. Often when the Hoffa fat pad is resected, the anterior horn of the lateral meniscus is split. The joint has now been adequately exposed. The degree of osteoarthritis can now be assessed laterally, medially, as well as in the patellofemoral joint. The size of the osteophytes is also estimated, and in this case, they are quite small. If there are a large number of osteophytes in the PCL insertion site, they should be removed to help determine the accurate entry point for the intramedullary guide that's being used soon for the distal femoral cut. The recommended entry point is usually located about 10 millimeters anteriorly and 5 millimeters medially from the PCL insertion site. The next step is to expose the anterior cortex of the femur, which is important when we later estimate the size of the femoral component. The synovial membrane can be opened with a Y-shaped incision and detached from the bone with a scalpel. If part of the synovial membrane looks inflamed, a partial resection can be performed. In some cases, a more extensive resection is necessary. However, resecting even a part of the synovial membrane should not be performed if there are no grounds for it. Now that the joint is exposed and the anterior cortex of the femur is visible, we can progress to the important phase of setting the alignment for the distal femoral cut. As mentioned earlier, our goal in this surgery is to align the cuts for the total knee replacement perpendicular to the mechanical axis. When preparing the femur, we first need to determine the angle of the distal femoral cut relative to the mechanical axis. However, since we can't directly measure the mechanical axis during surgery, we use the anatomical axis of the femur as a reference. We then apply the difference in angles measured preoperatively from the planning X-ray. This method allows us to achieve the correct alignment relative to the mechanical axis, even though we're using the anatomical axis as our guide during surgery. The anatomical axis of the femur corresponds to the direction of the intramedullary canal. This is why we can use an intramedullary guide during surgery to establish the anatomical axis. Now, to use this guide, we need to first determine its entry point. The entry point for the intramedullary guide is determined with the help of the PCL insertion site on the femur. Here's the PCL. Here we need to remove an osteophyte to expose the landmarks properly. The correct position for the entry point is 10 mm anteriorly and 5 mm medially from the PCL insertion in the femur. It's smart to mark the entry point with a sharp instrument before drilling. Make sure to position the instrument at the correct angle, which is the longitudinal axis of the femur. Then we'll drill a canal for the intramedullary guide. Hold the femur between your fingers. Place the drill on the marked spot and align the drill with the longitudinal axis of the femur. Use gentle pressure to drill deeper and let the drill find the medullary canal. After drilling, the canal can be evaluated with a separate rod. This ensures that the canal is in the medullary cavity and that the axis is parallel to the longitudinal axis. This is the intramedullary guide where we set the preoperatively measured angle between the anatomical and the mechanical axes. The angle is usually between 5 to 7 degrees, and in this case is 5 degrees. This will be the angle of the distal femoral resection. Introduce the distal resection alignment guide into the intramedullary canal. Make sure that the alignment guide is in contact with the femur to ensure that the resection thickness will be correct. Once you are certain that the alignment guide is placed firmly on the bone, assemble the cutting guide. The cutting guide will determine the thickness of the distal femoral cut. This is set by the manufacturer of the prosthesis. In this case, the cut will be approximately 10 mm in thickness. The cutting guide is attached to the bone with 3 pins, of which the first 2 are placed in the standard, also known as 0 pinholes. Using the 0 holes for the pins will allow readjusting the femoral resection by 2 mm in either proximal or distal direction later on, if needed. The third pin is placed from the lateral direction to hold the cutting guide firmly in place. Once the cutting guide is firmly attached, remove the intramedullary guide. The third pin can now be fully inserted. Next, we evaluate the planned resection with a resection guide, also known as an angel wing. The angel wing is also used to make sure not to resect too much bone. Now we've set the angle and thickness of the distal femoral cut and can move on to making the resection. Before proceeding with the planned resection, we need to protect the surrounding structures. Both lateral structures, especially LCL, and medial structures, especially MCL, should be protected with retractors. Set the saw to full power and proceed slowly so that it cuts through any sclerotic bone as evenly as possible. After completing the cut, you can use the angel wing to assess the result. The goal is to have even surfaces on both medial and lateral femoral condyle. Remove the pins from the cutting guide either with an extractor or with a drill. Then insert the intramedullary guide back to verify that the distal femur cut is in the correct angle, meaning the guide is even with the bone surface. The distal resection is now complete. Next, we'll proceed to the anterior and posterior femoral cuts. These cuts will determine the size of the femoral component in the AP direction. In addition to determining the AP size, we also need to position the component in the correct rotation. This is crucial to enable optimal patella tracking and for aligning the posterior cut with the tibial surface when the knee is in flexion. To measure the AP size and to align the rotation, we use this sizing guide. We are using a posteriorly referencing model. This means we position the blades of the sizing guide securely against the posterior femoral condyles. Then, we align the rotation of the guide with the transepicondylar axis. Here, the guide is preset to 3 degrees of external rotation. Typically, the difference between the transepicondylar axis and the posterior condylar axis is approximately 3 degrees, but this can vary among individuals. Despite using the posterior condyles as the reference point with the guide, our main objective is to align the rotation with the transepicondylar axis. The size of the resection is estimated by introducing the tip of the guide to the anterior cortex of the femur on the prominent lateral side. This is why we exposed this surface earlier. The size can then be read from the scale, and in this case is 9. Use pins or the drill to mark placement of the sizing guide in correct rotation. The sizing guide is then removed. Double-check the rotation before continuing. Reassess the location of the epicondyles to ensure that the marks are aligned with the transepicondylar axis. For demonstrative purposes, we're going to trace the transepicondylar axis. Next, the anteroposterior axis through the femoral sulcus is traced. It is a line running from the center of the trochlear groove to the top of the intercondylar notch. There will be a 90-degree angle between these two lines. This means that the rotation is aligned with the transepicondylar axis as desired. Insert the 4-in-1 femoral cutting block using the previously drilled holes. Secure the cutting block to the bone with either pins or screws. Use the angel wing to evaluate the upcoming saw cuts. Check that there is no so-called notching, which means that the saw cut ends posterior to the anterior surface of the femur. If it does, we would need to increase the component size. It's good to understand that when using this kind of posterior referencing technique, the cutting block is adjusted to resect the posterior femoral condyles to a specific thickness, for instance 10 millimeters. However, this thickness may vary between different manufacturers. If the size of the cutting block is changed, the thickness of the posterior cut remains at 10 millimeters, while only the anterior cut is altered. Consequently, the larger the cutting block, the thinner the anterior cut becomes. In a typical varus knee scenario, the thickness of the medial posterior resection is generally greater than the lateral posterior resection. Sawing proceeds sequentially from anterior to posterior cut, followed by the posterior chamfer cut, and finally the anterior chamfer cut. During the anterior cut, the anterior tissues are protected with a retractor. It is recommended to start sawing from the medial side and to continue towards the lateral side, so that the depth of the saw's passage can still be assessed during the cut. After this, we move on to the posterior cuts. Use a concave retractor to protect the medial structures, including the MCL, and the lateral structures, including the LCL and the popliteal tendon. You will feel the resistance decrease when you have achieved the correct depth. After the cuts, the cutting block is removed. Any loose bone fragments are removed, as well as remaining osteophytes. The posterior corner on both medial and lateral side is where the osteophytes can usually be found. The femoral cuts have now been made. Next, we start working on the tibia. The goal is to subluxate the tibia forwards for the upcoming extramedullary guide. The posterior horn of the lateral meniscus can be resected if it is still attached, as well as the ACL insertion here on the intercondylar eminence. Let's place a concave retractor behind the posterior edge of the tibia, because the popliteal artery and vein run in proximity to the posterior side of the knee. Stay close to the bone surface and gently guide the retractor behind the posterior edge of the tibia. The retractor will now help push the tibia anteriorly. When the tibia moves a bit anteriorly, you can perform a soft tissue release behind the eminence. Just make sure to stay right next to the bone with your scalpel. The release will help with the tibial resection and allows more mobility to the tibia. After releasing the tissues, readjust the concave retractor so that the tibia can move more anteriorly like this. Next, we can expose the lateral part of the tibia for better visibility. Slide the concave retractor on the bone surface to the lateral side of the tibial cortex and carefully secure the soft tissues behind the retractor. Also, pay close attention to the patellar tendon's insertion on the tibia and avoid excessive tension that may lead to avulsion of the patellar tendon. The lateral meniscus can now be removed with the scalpel following the edge of the meniscus. Both lateral and medial menisci are resected to make sure there will be no impingement with the components. You will need to do this resection under direct visibility to avoid damaging the nearby popliteal tendon. It is not necessary to remove the entire meniscus at this stage unless it is fully visible. Then the medial side. Resect the visible parts of the medial meniscus. A small counterpull adds tension in the tissues, making the resection of the meniscus easier. Special care must be taken to stay right next to the edge of the meniscus so as not to damage the medial collateral ligament. Also, the bony eminence can now be removed with a rongeur to help prepare for the upcoming steps. Just as we did with the femur, the tibia is also cut in alignment with the mechanical axis. On the tibia, the mechanical axis aligns with the anatomical axis. Therefore, we will make a cut perpendicular to this axis, which will align the joint line with the femoral cuts. Other important parameters to consider during this step include the tibial slope, and the thickness of the tibial resection. But let's first start by setting the extramedullary guide, which we will set to align with the anatomical axis of the tibia, which, as said, is the same as the mechanical axis of the tibia. One advantage of the extramedullary guide is that it can be used to bypass malalignments of the lower leg, for example on patients with previous fractures. The extramedullary guide uses the articular surface of the proximal tibia and the ankle as points of reference. The guide is placed so that the distal ankle clamps are first introduced around the ankle, above the malleoli. Next, the proximal part of the guide is placed against the anterior surface of the tibia. On average, rotation should be set according to the medial third of the tibial tubercle. The thickness of the resection is assessed using the pointer in this particular guide. In this case, we will resect 10 millimeters and use the intact lateral joint surface as a reference. This varies between manufacturers. After the extramedullary guide has been preliminarily positioned, it is secured with a drill bit or a pin. After the first drill bit, check the level of the resection. The hole on the guide allows moving the guide up or down. The pointer should make contact with the highest point on the cartilage. Next, let's evaluate the posterior slope of the tibial cut. The posterior slope is also determined by the specific implants and should therefore be checked in the manufacturer's instructions. The posterior slope varies vastly in normal anatomy, but on average it is approximately 7 degrees. Depending on the anatomy and the prosthesis-specific instrumentation, you can adjust the slope with the so-called finger technique. At the top, about 2 fingers wide, and at the bottom, 2.5 or 3 fingers wide. The further the distal part is moved, the greater the angle of the posterior slope gets. The guide should be placed perpendicular to the tibial axis, which is the foundation of the mechanical axis. Check the course of the guide relative to the longitudinal axis of the tibia. In the distal part, the guide should be placed slightly medially from the center of the ankle, which is located approximately 4 to 5 millimeters medially on the malleolus line. After checking all angles and the thickness of the resection, the extramedullary guide can be fixed with pins. The guide is fixed using the 0 holes, just like during the distal femoral cut, so that the thickness of the resection can still be adjusted 2 to 4 millimeters in both directions if need be. Also, the angel wing can once again be used to estimate the slope and the thickness of the resection. The concave retractor is now carefully placed medially to protect the MCL. Do not use excessive force so as not to cause any damage to the MCL. Once the thickness of the resection has been approved and the posterior slope has been checked, we can proceed to the actual resection. After all adjustments have been made, the cut guide is attached with a diagonal pin. Before starting the resection, make sure that the retractors are set securely medially, posteriorly, and laterally to protect the surrounding structures. However, it's important to avoid applying excessive force to prevent soft tissue damage caused by the retractors themselves. Keep the tip of the saw blade visible throughout the sawing process to avoid damaging soft tissues. Dismantle the extramedullary guide, but leave the actual mounting pins of the cut guide in place for possible additional resections. When removing the resected fragment, carefully release the soft tissues attached to it under visual control. The size of the tibial component can be estimated from the resected part of the tibia. First, we will verify that there are no osteophytes on the medial side of the tibia. Gently release the medial structures along the tibia to expose possible osteophytes. A ronger can be used to remove smaller osteophytes. The remainder of the medial meniscus is removed. Again, the assistant can help by applying counterpull so that the tissues can be separated more easily. All visible parts of the meniscus are resected with a scalpel. Use diathermy to coagulate all visible blood vessels at this point. After the removal of the meniscus, the vessels often retract posteriorly. Let's move to the lateral side. The concave retractor is placed on the lateral side of the tibia behind the cortex. Grab a hold of the remaining part of the lateral meniscus. Pulling gently on the meniscus eases the resection. Remove the meniscus sharply while simultaneously making sure that the popliteal tendon is not damaged in the process. A branch of the inferior genicular artery can usually be found laterally, and it should be cauterized. The popliteal tendon is clearly visible, and the bony surface of the tibia is now ready for the fitting of the trial components. But let's finalize the femoral side first. Next, the cartilage on the posterior condyles of the femur is removed, and the posterior spaces are thoroughly cleaned out. This makes room for the femoral component and enables better flexion of the knee. Place the joint spreader carefully between the tibia and the medial posterior femoral condyle. Identify the cartilage on the lateral femoral condyle, and using a chisel, remove the cartilage on the posterior condyle. Remove loose fragments. Use your finger to check the posterior space for loose fragments and osteophytes, and to make sure there is enough space for the components. The same procedure is then carried out on the medial side. The joint spreader is positioned laterally. The edge of the posterior cartilage surface is identified and removed using a chisel. Often there might be an osteophyte in the lateral part of the medial condyle that can be chiseled off. Again, use a finger to make sure the posterior space is now cleared, and there are no loose fragments or osteophytes. The remnants of the ACL are then sharply removed, using either a diathermy or with a scalpel, while making sure not to damage the PCL. The PCL is here, the posterior spaces are now cleaned off, the PCL is intact, and the ACL has been resected. With the knee in 90-degree flexion, assess the general balance and the symmetry of the laxity. Note that there are specific instruments, not shown here, that are used to assess balance in flexion and extension, in addition to tactile feedback. Do the same with the knee in 30-degree flexion. The laxity is also assessed with the extended knee, and in this case it seems quite symmetrical. To roughly estimate if the axis of the knee is straight, push both bone surfaces against each other. Often, if these tests reveal an asymmetrical result, the first step should be to check whether the saw cuts were performed precisely according to plan. Now let's put in the trial components. Remove the guide pins. Since we have previously established that the resection is sufficient, the need for further resection should be unlikely. Using a tibial trial component, we'll try to find the perfect fit. The component should match the edges of the tibia without extending beyond them. In this case, we are using an anatomical component, where the medial condyle is larger than the lateral condyle. If the tibial component is undersized, it might sink into the spongy bone. Typically, the rotation that we aim for aligns with the medial third of the tibial tubercle, meaning external rotation. This ensures optimal function of the knee replacement. When positioning the trial component, it's crucial that the component does not extend beyond the tibial edge on the medial side. This could cause friction on the medial tissues, primarily the MCL. The same principle applies to the lateral side and the lateral tissues, as well as posterolaterally, in which case the metal can rub against the popliteal tendon. It is difficult to treat these problems without reoperation. Once the tibial component has been positioned as desired and confirmed to align with the bone, the component can then be secured in place. Check the correct rotation. Make sure the component does not extend beyond the edges of the tibia. The tibial trial component is now secured in place. Once the tibial trial component has been attached, the rotation is checked once more, and it should align with the medial third of the tibial tubercle. Use diathermy, for example, to mark the correct rotation in case the component gets twisted during the procedure. Position the first plastic spacer into place and proceed to insert the femoral trial component. The femoral trial component is put in place. The size of the component corresponds to what we determined during the preparation for the anterior and posterior femoral cuts. Check that the component seems to fit in the mediolateral aspect and then tap it into place. Make sure that the femoral trial component is still mediolaterally perfectly aligned with the femur and it fits snugly on the bone surface. You can estimate the flexion gap with the help of the handle. The knee must feel stable and both medial and lateral gaps should seem symmetrical. In this case, the gap is larger than desired, which means that we need a thicker plastic spacer. At 90-degree flexion, there is 2 to 3 millimeters of extra give on both sides. Then we examine the balance on extension. Extend the knee carefully. Should there be excessive tension during the extension of the knee and the joint is forced into extension, this could lead to a ligament rupture. Assess the axis of the limb as well as the congruence between the components once the knee is fully extended. Both are aligned here. Also, the mediolateral balance is checked. In this case, there is some laxity both medially and laterally. Since the knee feels symmetrically loose in both flexion and extension, we can fix the issue by opting for a thicker plastic spacer. Let's check the patellar tracking. Turn the patella in place and gently flex the knee. The patella should glide smoothly in the patellar groove of the femoral component. We have now established that there is some mediolateral laxity on both medial and lateral sides, quite symmetrically, in both flexion and extension. The tissue laxity can also be tested with the knee and semiflexion using a sem rasp. In this case, the tissue laxity is very symmetrical. Now, we continue to fit thicker spacers until we reach a state where the knee is balanced in both extension and flexion. First, a 11 mm trial spacer was used. Next, a 12 mm trial component is tested. Still a bit too much laxity. Let's try a 13 mm trial spacer. The tissue laxity is tested using the SEM rasp. Test the stability during the entire range of motion. Seems quite symmetrical on both sides. The knee now appears to be stable in both extension and flexion. The joint can be fully extended without tension. Check the movement of the patella. It seems perfect. Double-check to make sure that the knee can indeed be fully extended. It's good to know that when the knee is in hyperflexion, a lateral gap can be seen, which is a common feature in a varus knee. However, hyperflexing the knee does not create a gap on the medial side. This can be explained by the medial pivot effect. After these assessments, we can conclude that the knee's ligament balance is now symmetrical. The trial components are now in place, and the final plastic spacer has been chosen. Check that the femoral trial component is still mediolaterally aligned with the femur, and drill in holes for the pins of the actual femoral component. Make sure that the drill goes all the way into the bone on both sides. Remove the femoral trial component. Remove the plastic trial spacer. Bring the tibia anteriorly for better visibility. Make the necessary preparations for the keel and the shaft of the tibial component. Refer to the manufacturer's instruction manual to select the proper tools. Insert an additional screw to the tibia to ensure that the keel and stem are placed into the correct position. Use the previously made rotation mark to ensure that the rotation is still correct, even though the tibia has been moved around a little bit. A drill guide is placed for the component stem. Drill to the correct depth. This will depend on the size of the component. Make sure the drill goes down all the way. The passage for the keel of the component is now prepared using a hammer. The keel will ensure the rotational stability of the tibial component. If the bone is very sclerotic, an additional saw cut can be performed on the sclerotic side to prevent fracture of the tibia. Make sure the keel punch is advanced into its maximum depth, so there will be enough room for the keel of the tibial component. Remove the screws of the trial component. The tibia is now ready for the cement and the actual component. Wash off all the excess fat and blood so the cement will engage with the spongy bone matter. Fat cells under the cement weaken the tensile strength significantly, so a meticulous wash is essential. It's important to make sure that all necessary instruments are available and the correct components are checked and readily at hand. This is because the cement will harden in about 11 to 12 minutes, and so at about 6 minutes the components should already be inserted into the patient. The OR team should be made aware of all intraoperative steps before the operation. Maintaining open communication within the team is crucial for success, given the relatively brief window of time available for working with the cement. After the wash, the bone surfaces should be dried carefully. Gauze can be used to dry the bone surfaces. A bone plug can be introduced into the femoral medullary canal to prevent cement from entering it. One final check to make sure there are no soft tissue remnants left between the component and the bone surface. It is important to first apply the cement on the components. The next step is to apply cement to the bone surface of the tibia with a cement gun and pressurize. And also to the stem hole. Any condensation that appears on the surface of the cement can be dried with gauze. Next, the actual component is introduced into its place. Use care to guide the component and make sure to achieve the desired rotation. Remove excess cement around the component with meticulous care, especially from the posterolateral corner, where it can easily be left behind. Tap with the hammer and make sure the component is perfectly flush against the bone surface. Again, any excess cement is checked for and removed. Now, either a temporary or the final plastic spacer can be installed. We decided to install the definitive spacer. Before moving on, see if there is still some cement residue to be removed. Now the femur. Make sure to pressurize the cement. Then install the femoral component and use the pinholes as guidance. Excessive force is not necessary. A calm, resolute manner will suffice. Remove the excess cement. The components are now in place. Extend the knee with care and check if there is need for removal of the cement. Make sure that full extension of the knee is achieved, the components fit perfectly, and that the knee seems stable. The knee is brought to flexion, and the cement from the intracondylar area is debrided. The knee is now stable at 90, 60, and 30 degrees of flexion, as well as full extension. The patellar tracking is impeccable. During total knee arthroplasty, the movement and the condition of the patella should always be assessed. The decision on patellar resurfacing should be considered based on the surgical findings as well as the patient's preoperative symptoms. Current studies suggest that selective resurfacing is recommended. In this case, the patellar cartilage is in good condition, the shape of the patella is normal, and the patellar tracking is perfect, so there is no need for resurfacing the patella. Meticulous closure of the arthrotomy is very important for a great outcome of total knee arthroplasty. Attention should be paid to exact tissue apposition. We begin the closure from the arthrotomy. You can start with so-called reinforcement sutures in the upper medial corner of the arthrotomy. This can be done with mattress sutures and will lead to reliable apposition of the tissues. Use number 2 thread, for example. We now move on to the distal part of the arthrotomy. As there is very little subcutaneous tissue here, the first suture can be inverted. With an inverted suture, the knot will not cause a suture fistula, which will help fend off a possible infection. You can proceed with continuous suture to the proximal direction. Aim for a watertight closure of the arthrotomy. The continuous suture may overlap the reinforcement sutures. As the sutures bypass the proximal patellar edge, the knee is brought to flexion to get adequate tension on the sutures. With the knee in flexion, the durability and the watertightness of the closure can be assessed. Suturing is continued proximally. Use a finger to see if the arthrotomy incision still needs sutures. At the end, you can go back a few centimeters and finish the suture there. Bring the knee to extension and flexion a couple of times to see if the sutures hold nicely. Then, the subcutaneous layer. In this case, there is very little subcutaneous tissue, but intracutaneous sutures should be avoided because of possible risk of cutout. At the proximal end, the knee can be brought into a slight flexion so as not to create tension on the closure. After the subcutis has been closed, we close the skin. Pay careful attention to the tissue apposition. The incision was done with a flexed knee, so we're going to close it in flexion as well. A continuous mattress suture is used.